This is Bethany with the Birth and Body podcast. Welcome to the show. I'm really excited about this episode today because we're going to go over a lot of questions we often get asked as far as how we take care of newborns, what that looks like right after birth. So Kim, my student in my practice, is back on the show. She is almost done with her training. She's in her primary under supervision phase. So probably a lot of you listening are using her as your midwife. She's a student with National College of Midwifery. So welcome.
Yes, thank
you.
To
the show. Thanks for being willing to come back on
Sure.
and talk with me about how we just make sure newborns are healthy beginning from birth.
Mm-hmm.
So, and I really feel like a lot of these questions we just go over so often in prenatal care as we lead up to the birth. So I thought we could start with really just how we assess the baby from the moment, we see them for the first time. So I think a lot of people, especially when they are considering switching to home or birth center birth, usually the number one question often is safety. How do we keep people safe? And if something goes wrong, quote unquote, what do we do? So often we're explaining, we take APGAR scores of the baby. We're able to tell if they need to be resuscitated. We have that equipment if we need to help them transition to the outside world, all that kind of stuff.
And we do monitor the baby during labor.
Right. So often we can kind of predict of what babies are going to need help.
Yes.
Which aren't. And depending on the situation, sometimes that means we're transporting. But often if we're having the baby at home or the birth center, we've had good heart tones the whole time. And I think, only 95% of babies are going to transition well.
Mm-hmm.
You've probably studied this more recently than I have. Only 5% need help breathing and things like that. So
because they actually go from being in fluid to learning to breathe air or just their lungs transitioning, and they have about a minute or so to do that, and we watch them through that process.
Yeah, it's interesting. It's with neonatal resuscitation, it's different from adult CPR, in that we're really just trying to get that fluid out of their lungs. Once they do that, they can breathe, they pink up, transition great.
Right. So one of the first things when the baby's head comes out, before in the past, people or doctors would suction the baby.
Right. That's true.
And a lot of times parents are like, well, do you need to suction? Do you need to suction the baby? And we don't routinely do that anymore. Mm-hmm. I don't think they do that in the hospital routinely.
Right. I think it used to be part of neonatal resuscitate, stimulation. When you're drying off the baby, everyone would get suctioned. Right. But I think, and you may have studied this more recently, but I think they saw just suctioning in their mouth without a reason, it actually affects breastfeeding. Yeah. Often they were getting that too far back in their mouth, and then they were less likely to latch well. Right.
And it can stimulate the vagus nerve, which can cause other problems for the baby. Mm-hmm. So we don't actually suction unless there's an obstruction that hinders them from breathing, actually.
Yeah. So once we know baby's doing well, we really just keep mom and baby together.
Right.
And I think they, just in our medical model system, that's not what you see on TV or anything. Mm-hmm. So at least, you can comment. But I feel like a lot of our clients ask, well, when do you weigh the baby and all this stuff? That's not important.
Yeah, that's not the first thing. No, the first thing is to have mom and baby together. Mm-hmm. So there's so many good things that happen when they're skin to skin together. Baby relaxes. There's less crying. The baby hears the mom's heartbeat and can smell the mom and recognize her voice and just relax. And the mom starts bonding with the baby.
Mm-hmm. And I think it's amazing how the baby often regulates heart rate and respirations just by being skin to skin and taking its cues from the mom's vitals.
And one thing I learned in school that I love is that the mom's body helps regulate the temperature of the baby. That's fascinating.
Yeah. It's amazing. If baby's cold, the mom's body will heat up to heat up the baby. Yeah.
Yeah.
So interesting. Mm-hmm. Everything, babies do so much better when they're with their mom.
They really do. And it's such a sweet time because they're just discovering the baby for the first time.
Yeah. Yeah.
Baby's finding comfort. And it's a great opportunity that leads up to breastfeeding. So that's probably our next step after skin to skin.
Yeah, I think a lot of not everyone, but the majority plan to breastfeed Maybe you could talk a little bit about that.
About the benefits of it, or how that happens,
or why we don't separate them.
Yes, well, it's just a really natural, I've heard it called the magical hour after birth, when babies can find the breast on their own and start rooting. And then, of course, as they eat, that stabilizes their blood sugar, and all those just sweet bonding things happen. And it's so healthy for baby to breastfeed. And the mom's body responds to the baby if the baby's been exposed to bacteria or things that might be harmful. And
that's true.
Just strengthens their immune system for their future.
Yeah.
Yeah.
Yeah. And I think often after the first hour, baby starts to get tired. So we really don't want to miss that wakeful period that the baby has. That's the best time to initiate breastfeeding.
Right.
So we put off all the non-necessary things that we can do when baby's a little more sleepy. So
So after baby comes out and we assess vitals on baby, make sure mom's doing fine, let them be together. We try to give the family about an hour to bond before we do anything else. And I feel like some people are like, wait, what? You are going to leave us here to just bond? And we're just right next door, in the next room. But it gives them time just to be together. And it's a really sweet time. And we can usually assess the baby by the color of the baby and how the heart rate is. That tells us a lot about circulation and oxygenation of the baby. So, of course, we're checking on all those things, but we give them time just to be together and bond.
Yeah,
and
for sure.
Figure out those first few moments together and count the toes and all the fun things. So.
Yeah. And, I think just catch up, too. Sometimes after a long labor, like you just need to take a minute and realize, oh, that just happened. That was a big deal.
Yeah.
Yeah.
For both mom and baby.
Yeah. Yeah, for sure. And I think a lot of our clients ask about delayed cord clamping.
Yes.
And they often don't realize we kind of do more than delayed cord clamping.
Right.
Because I think the definition of delayed cord clamping is just 3 minutes after the birth. Because I think that's, used to be where they cut the cord right away. And then they've only done research, I think, up to 3 minutes.
Wow. Yeah.
That
doesn't seem like very long.
No, it's not long at all. Right. So, especially on consults when people talk to us for the first time, they often ask about that. And we usually just don't cut the cord or anything until after the placenta is out.
Right.
And usually the cord is still pulsing for a while. So I need to look back and see what our averages are. But I think a lot of times we wait over an hour.
I think so too.
Yeah.
I think that's really common. And we'll just wrap the placenta up in a Chex and put it aside and let the family be together. The only times I think we would tend to cut the cord is if the baby were really wrapped up in the cord and couldn't come out, or if there was some other emergency situation. But we just we don't rush.
That's true. Yeah, that's true. Especially when someone really wants it. That's true. We always talk about how if the head is born and the cord is just wrapped around the neck so tight that we can't birth the rest of the body, that might be a time to cut it. But otherwise, thankfully, I've never had that happen.
Right. And even though babies come out with the cord around their neck sometimes, usually they can just somersault out of that. So,
yeah, not usually an issue.
It doesn't mean we're necessarily cutting the cord. So.
Yeah.
And when we do cut the cord, there are lots of things we can do.
That's true. Yeah.
So, recently at a birth, we had someone use a really cute little cord tie that she bought off Etsy. And I had not ever experienced that before, but that was really kind of cute and different. Do you want to tell us about that?
Yeah, so that's true. It was the first time we had someone do that. And obviously I guess for people that don't know, especially if it's their first baby's born, placenta's born, skin to skin, baby with mom. Often like you said, we set the Chex by the mom. So,
which is just a pad to catch.
Right. So everything's not going everywhere. That's true.
We just like a big little envelope we can wrap the placenta in.
And then the cord just stays attached till it's done pulsing. Baby gets all of that blood, stem cells. There's like a third of their blood supply in the cord if they cut the cord right away. So we want them to get everything. They do so much better, especially if we need to resuscitate. So once the cord's done pulsing and and it is kind of like completely white, all of that blood is in the baby.
And then we can even milk the cord where we take it and
make sure the baby gets everything.
Pinch it down. Make sure they get everything.
Yeah. Yep. So then once that's done, like you said, we will clamp and cut the cord, or some people would rather use the cord tie instead of like a plastic clamp, which is, I guess it's, the cord tie is more like thread, I guess you could say. And it's just softer. And she found, what I liked about it so much, that option is that the umbilical cord dried so much faster first compared to the clamp. That's why I liked it, because I think by 3 days it was done. Wow. And it just was less to deal with.
Right.
So that's an option if someone doesn't want a cord clamp.
Yes. If we do clamp, we usually take it off at a 2-day visit or something like that. And
when we come to their house,
about, 3 centimeters or so from the umbilicus, then we'll put the clamp and then cut the cord, and it usually dries up in a week or so. Yeah. And baby does well. There are some other things we can do. There are things called cord bands. It's like a rubber band we can put on the end of the cord. And then you just had a really sweet birth recently where you did a cord burning.
Yeah, that's true. I had a client really want to do that. So I've only done it a handful of times. Right. It takes a while, and different cultures where it's kind of a traditional cultural thing for some people, where maybe they didn't originally have access to, like, sanitary options to cut the cord, so they would usually burn it just to cut down on infections through the umbilicus. So, and it's just the way it sounds like you have sort of like I should have brought it, but
the little box.
Yeah, a cord burning box. The baby's next to it, and then the umbilical cord sort of across, and then usually mom and dad each hold a candle to cauterize the cord, and that's how it's severed from the placenta. And it takes a while. I think that's the downside, is it takes like 10 minutes, but there's no way that the baby can get an infection through the umbilical cord when it's cauterized, which is nice, I think. And it's just kind of a sweet, like, it really slows down the whole postpartum period. And I think a lot of families like it because you have to reflect more on, wow, this just happened, and some people want to pray or do different things. So
you could even include siblings, which is kind of a fun thing. Make it a little family event.
Yeah, that's true. I had a Neller client who each grandma held the candle.
Oh, that's so sweet.
Yeah, it was a sweet way for them to be involved. So, yeah,
that's good.
Yeah. So after that, we usually get, after baby is separated from the placenta, I guess, usually at that point, dad is holding baby, and then we get mom up to the bathroom, take a shower, those different things. And then after that, I guess usually an hour and a half after, that's when we're usually doing the newborn exam.
Right.
So we don't have pediatricians like the hospital at the birth, but midwives are trained to take care of newborns till 6 weeks postpartum. So, or when they're 6 weeks old. So we look at all the things, make sure everything's normal.
Right. Measure the baby, the length and the head and the chest, and listen to their heartbeat. And then there's some options for parents to decide on there. And a couple of the big ones that come up next are antibiotic eye ointment.
Yep.
And then vitamin K. And I think there are lots of maybe myths and rumors and misunderstanding about some of those things, what they're for and how people should choose them. So I know we have a few websites for information that we like, that we send people to say, hey, just get the facts and then decide what's best for your family.
Yeah.
So
what are some of your favorites lately as you're studying it too, for finding out, what are my options? What's best in this?
Yeah, I really like evidence-based birth. I feel like she does a really good job at looking at all the options and reviewing the studies and things like that. So I think she does a good job. And then I like Aviva Roms as her website as a resource for lots of different things. So
yeah, that's true. I forget she's got lots of pregnancy, newborn, like, information on there too.
Right. She was an herbalist and a midwife, and now she's a doctor. So I feel like she has a broad range of knowledge and considers all of it when she gives advice to her patients. So
yeah, totally. Yeah, I think a lot of families ask us when we do, the eye ointment or the vitamin K, and we don't do it till probably 2 hours postpartum usually, so they can bond, and then we always give them the option. Like, a lot of people don't understand. We really give them what we call informed consent, where they get all the information. We want them to research. We want them to look at all their options.
We don't just tell them what to do.
Right. Which is frustrating for some people, because they want to do the right thing, quote unquote, but it's not a black and white issue for either of those options. So
And so erythromycin in the eyes, that's the antibiotic ointment. What do you tell people trying to decide? Why do they need it? Why should I put that in my baby's eyes?
Well, I think just like any procedure, they all kind of have an interesting history. So the eye ointment started because I believe it was, I forget what
year. The 1930s.
Yeah, early 1900s. They were using silver nitrate, I believe, because a lot of babies were going blind from their mothers not having, I think, syphilis, and then eventually some other
sexually transmitted infections
treated. So they were contracting infection, which would attack the baby's eyes and lead to blindness. So they started putting these silver nitrate in every baby's eyes to prevent that, which kind of the evolution of it ended up becoming erythromycin eye ointment. Again, every baby's eyes, assuming we don't know who does or doesn't have an infection. Granted, most of the time we're going to test our clients for those things, so we know who does and doesn't have, who isn't at risk for that. So I kind of feel like it's half and half of our clients who maybe choose it to have it in their baby's eyes, where the other half feels like that's not, necessary for our family.
There are other infections that it covers besides gonorrhea and chlamydia and
recently found
sort of things. So some people just think, well, I'd rather do it to be safe than sorry. So
and as far as we know, there's not risk. I think there's some research on that type of antibiotic starting to become resistant to certain bacteria. So now they're concerned about, putting it in everyone's eyes, that could start to be a problem, which is understandable. The antibiotic resistant bacteria, or bacteria resistant antibiotics, excuse me, you know what I'm trying to say, is definitely starting to become an issue. So but what other questions do we get asked about chlamydia or gonorrhea, eye ointment, all that stuff?
I don't know how much you want to say on the podcast.
I mean, I think that's the general, and that is not required anymore. It used to be law that every baby had to have it, or else the parents or the provider could be incriminated if they didn't do it. So
so I don't know how much you want to say. Sometimes people can have an infection they don't even know they have. It can be dormant for 3 years or so. And so that's one reason we do test early in pregnancy, just to make sure those things don't exist. Some people don't realize the way they can get different kinds of sexually transmitted infections. So it's just good to test and know what your status is, and then just decide what's best. And those decisions are really personal. So just make sure you're educated and you research it, and then make the best choice you can with the information you have.
For sure.
And what's really interesting is 2 people can hear the same information and come to completely different conclusions.
Absolutely.
But
for sure.
You just have to do your homework and then decide.
100%.
Yeah.
And then the other one we usually offer at the newborn exam is the vitamin K, which kind of same thing, can be polarizing a little bit. Everyone has different opinions about it.
They do.
So,
really so there are options. We offer a vitamin K injection at the newborn exam. Some people don't want to give their baby a shot. Just because they think, that would hurt and it's a brand new baby. And so they ask about vitamin K, or not oral, drops. Yeah, it is oral drops. Yeah. And
like liquid,
Liquid, yes. And that has been popular in other countries at different times, and they've done studies. And we don't have a great resource for that in the U.S., and it's not FDA regulated. So usually that's the main thing we tell people is when they get an injection, we know how much they're getting, and with drops, we don't always know. And when you do drops, some people think, oh, I'll just give them the drop. But if you decide to give them drops, you have to actually do it weekly for up to 6 months. Mm-hmm. So that's very different than one injection.
Right.
And plus, they have to be fed while they're getting drops. They have to, if they're breastfed. And then what if they throw up? How much did they keep? And so it's a little bit more difficult to monitor. Mm-hmm. But one thing people ask, I think often, they don't understand. I had a conversation with a client yesterday about this, is why do they even need vitamin K? Is it a vitamin at all?
Right. That's true. Like, a lot of families feel like, my baby's perfect, which usually they are. Why would they need something else?
Yeah.
So
didn't God make them with everything they need?
Right.
Yeah.
It's so interesting. Yeah. I think with babies being born and their gut is sterile, a lot of people don't realize that the vitamin K is made in their gut. Mm-hmm. So they're not able, their gut is not mature enough until 8 days after to really start making vitamin K. And vitamin K is necessary for clotting. So a certain number of babies are going to have blood clotting issues, which could lead to bleeding on the brain and the newborn hemorrhagic disease, which is what
this protects against.
Getting the injection protects
against. And they can't store it in their liver, and it doesn't transmit through the placenta well. So
Right. So it's not like the mom can take it prophylactically in pregnancy
and then give it to the baby.
Right.
It just doesn't work that way. And then we can't see if the baby's going to have a problem, and they can have an issue for up to 6 months. So
because there's the early onset vitamin K deficiency bleeding, and then the late onset, which is why if they're going to do the drops, they have to take it for such an extended period.
Right. And I was reading sometimes if a baby has an underlying gallbladder condition, then often they'll start bleeding, and that often happens in the brain.
Which can be really dangerous. Yeah.
Right. For up to 6 months. So you have to just decide. Yeah.
Kind of weigh the risks of the drops, and that potentially... Often the drops are K in olive oil or something, and giving them something that's not breast milk or made for a baby like formula, how is that going to impact their gut? We don't have information on that. And then, or potential risks of the injection, which we always give information on the package insert so they know what is in it. In order for an injection to be shelf stable, there's going to be things in that besides the actual vitamins. So injecting a baby with that versus not giving them anything, and we don't know which babies are going to have this vitamin K deficiency bleeding potentially. Right. So it's a hard one. I feel like it's easier to choose to have a home or birth center birth because there's more research on that. It's a little more black and white than something like the newborn procedures or vaccines or can be hard to decide. And I know some families, they choose different things with different babies. Maybe they have more information and they choose something else with a subsequent baby, and that's fine too. So
I remember making those decisions for my own kids, and I remember a doctor saying to me, well, don't you care about your baby? And I was like, of course. That's why I'm asking questions and researching and trying to figure out the best thing for my baby. So we like people to ask questions and read and investigate and things like that. So
yeah, for sure. So lots of options in the first few hours. Yes. But we like to give that information ahead of time so they can think about it and not get too blindsided once their baby's here.
It can be overwhelming.
Yeah. So once, all those decisions have been made, we've done the newborn exam, everything looks good. If we need to, we'll refer to a pediatrician. Often we're leaving their home at that point, as long as mom and baby are stable.
One question we always get before we leave is, should I give my baby a bath? What about that one?
That's true. That's true. Yeah. Why do you think people ask that?
Babies often come out with vernix on their skin, and they're like, what do I do with this? Sometimes it's a white, sometimes thick, kind of cheese-like covering, and they're not sure what to do with it. Do I rub it in? Do I wash it off? What is it? But it's actually good for the baby's skin. It's a protectant. And we usually just tell people to leave it alone until the baby's cord falls off, and then they can kind of sponge dry the baby, or sponge wash the baby, sponge bath the baby, bathe until until the cord falls off, and then they can think about bathing their baby.
Yeah, that's a good question. I think often they sometimes more routinely bathe the baby in the hospital.
Yeah.
So, yeah.
Who doesn't want a fresh, clean smelling baby?
Right, totally.
Yeah,
that's true. And then we usually come back 24 to 48 hours after either their discharge from the birth center or we leave their home and check on a lot of things again.
Yes. How's breastfeeding? How many diapers? How are you doing emotionally?
Yeah.
Do you need to process the birth? Let's talk about how everything went.
Yeah, and we do the newborn screen at that visit if they want to.
Yes.
Which I feel like sometimes is the worst part of our job because it's a heel prick on the baby and getting blood spots on a card and then sending that off, and it's hard for the family, but it tests for so many things.
Right.
So many metabolic disorders. I think over 66 now. Wow. I get emails every now and then with new things that they're adding.
I thought it was at 54, so I'm behind.
Yeah, no, I've already got a couple emails this year about it. So we send that off if people want to do it. And then I think a lot of people don't realize we do the critical heart defect screening with the pulse ox, just like they do in the hospital. So almost, which is just like a pulse oximeter. We attach it to their hand and their
little
foot.
Sensors. It doesn't hurt.
It's like a light that looks through their skin to see their oxygen levels. So super intervention, low intervention. And the only thing they really have to get with a pediatrician would be the hearing screen and vaccines.
And if they decide to circumcise their boys.
Yes, that's true. That's true. I always forget about that one.
Yeah. I don't think anybody likes to remember that one.
Yeah. Awesome. And then what does, after that 2-day visit, how, now that you're doing it, what does that kind of look like for follow-up?
We stay in close contact with our moms for every day or so. We make sure we're calling them and texting them, and how's it going? Do you have questions?
Yeah. How's
baby eating? Babies usually lose about 10% of their body weight when they're born. We don't want them to lose any more than that, so maybe up to 10%. So we just make sure babies maintaining weight and eating well and making good diapers and check on jaundice. I'm trying to think of other things at that first visit. And then, of course, checking on mom and making sure she's healing well as well.
Yeah.
Not in pain and eating well. And
totally. So many things. We had a few episodes ago, we had Jessica on, and she talked about just the postpartum care and how that's really helped her just with like mood disorders and different things. So just a lot of follow-up versus seeing them just, at their home or birth center and then not seeing them for 6 weeks. We see them a bunch.
Sometimes I feel like I'm bothering the moms. Like my doctor or my midwife, I didn't have a doctor, but she didn't call me every single day. And I'm like, hello, it's Kim again. How are you?
We really want to make sure they're doing good and thriving.
Doing okay? No, I don't need anything. I'm fine. But that's okay.
We really want to check on them. So, and then they come back to the office for the 2-week postpartum visit, and kind of same thing.
And that's their second newborn screen if they choose to do that.
Yep, that's true. That's true. Yeah, I think a lot of people don't realize that it's helpful to have one when the baby has not been processing milk as much, and then when they have, because sometimes one may not catch what the other one does.
Right.
So that's why we always offer 2.
I actually don't mind doing that.
You don't mind it?
I don't.
You're good at blood draws and stuff like that. So
sometimes. But it just doesn't, it seems like a lot of times if the parent is holding the baby, they tolerate it really well,
or if they can breastfeed while we're doing it, that heel stick. So
I feel like they get more aggravated just by the fact that we're messing with their feet than
touching them,
getting a couple drops of blood. So
it's true. Cool. Then sometimes we'll see people at 4 weeks, but we definitely do the 6 week and want to weigh baby and troubleshoot breastfeeding.
Those are the fun appointments. The fruit of all the labor from the months before.
See all the babies.
And fun little pictures at the end, like, you did it! You're awesome! And your baby's awesome.
Yeah, awesome. Well, anything else you would want people to know about newborn options or care?
Wow, I don't know.
Or from your experience with raising 4 kiddos?
Yeah. I don't know that I have anything.
I wonder, I feel like a lot of families, they aren't quite prepared for maybe the lack of sleep.
That's
or
true.
They tend to compare to other moms and what they say about lack of, or, just how postpartum goes.
Right. I think that's one reason why we try to bring up at around 36 weeks, hey, do you have a postpartum plan? Do you have someone to help you? Do you have somebody bring you a meal? Right. And help out with the laundry, because you don't have to be super mom and do everything the whole first week after you have a baby. In our culture, we don't take time a lot of times to let mom heal and just enjoy the baby and things like that. So if you have a plan, I feel like that really helps with family adjusting and with mom feeling better and
for sure.
just being able to enjoy the baby. Things like that.
For sure. Because you just never know. Like, some moms have a hard time with breastfeeding, or it's painful, or there's a lip tie or tongue tie.
And we're so much more aware of postpartum depression and baby blues, and people thinking, oh, should I be feeling this way, feeling kind of down and overwhelmed, and this is a lot. And it is a lot to have a baby.
It is. It's a big transition.
It's a big transition, even if you've done it before.
Yeah. To have a little person depending on you can be a lot. So
yeah, it's super wonderful and can be hard, but worth it.
Yeah, for sure.
Yeah.
Well, thanks for coming on the show and helping me just talk about this whole topic, and
it was fun.
Dispel some myths and hopefully help people be a little more prepared for what to expect.
Right. So hopefully we'll be ready for everybody's questions when they come in.
Ask us if you have more questions about postpartum or newborn care, for sure.
Yes.
Awesome. Thanks, Kim.
Okay. Thanks.
Let us know what you want to hear about, and if you've made it all the way to the end, please leave us a review. We would so appreciate that. Share about it. You can find more updates and things like that on my Instagram or Facebook. It's at Bethany Stricker Midwifery on Instagram, Bethany Stricker Midwifery Care on Facebook, and then just BethanyStricker.com for website stuff. And make sure you subscribe on Spotify or Apple so you can get notifications for further podcasts. Thanks for listening. Bye.